Good afternoon, and welcome everyone to the Ask the Expert webinar. This webinar is part of the 2022 OSU Mental Health Fair. I am Dr. Ken Yeager, and I will be the moderator for today's event. Before we get started, I have just a few housekeeping items to cover with you. This event is being recorded, and it will be posted on our website at a later time. All attendee microphones and videos have been turned off and will remain off for the entire session. The chat and Q&A features are available for you to communicate and ask questions of our panelists. We would ask that you do not use these features to communicate with other attendees. When asking questions of our panelists, please do not disclose any private health details or questions on your personal diagnosis or treatment. All questions should remain general in nature. And just a reminder or disclaimer, information shared during this session features the thoughts and perspectives of our panelists and is intended to be educational for the general audience only. The panelists are not providing medical advice, psychological advice, diagnoses, or treatment. Always consult your healthcare provider for questions or concerns about your health or that of a loved one. Finally, closed captioning is available through Zoom by simply clicking on the closed captioning button at the bottom of the page. To begin our webinar, we would like to share with you a short video that has been prepared by members of our Mental Health Fair Planning Committee. This video is meant to highlight the incredible and passionate individuals who work at OSU and Harding Hospital and Talbot Hall. These individuals that have devoted their lives to the treatment of mental health or addiction will be sharing with you their experiences. Often this means going above job duties and occasionally putting themselves at risk to provide outstanding care to their patients. Let's start the video.
May is Mental Health Awareness Month. Join me in coming together to hear inspiring stories from Harding Hospital staff as they not only recount the many reasons why mental health is important, but why they choose to show up every single day to make a difference in someone's life.
That's an interesting question because I didn't really choose to go into mental health. It kind of chose me, and it was an amazing light bulb went off, and I said, "Oh my gosh, I was meant to be here."
I love it.
Every single person in this building has so much potential, and that's the job of staff here, is to find that potential and make them feel like they have that potential too.
I'm really passionate about the care. I switched from clinical to administrative work because I was really passionate about making sure care remains accessible and affordable.
I think that we come from it from several reasons, but for me, there's always a personal reason. And for me, as a child growing up in adversity and trauma, I've always struggled with meeting with people and trying to figure out how to balance a past history that they may have had that makes them struggle, and how to move them from a place of struggling and challenge to a place of resilience and a place of growth.
So growing up, my family is riddled with addiction, and just being since a child always like, I'm gonna fix them. And you know, if you don't want fixed, there's no fixing people. So I was like, I'm gonna go to school and I'm gonna help fix the people that want fixing and do the best that I can. And it's just been very rewarding.
I honestly feel like mental health is almost like the underdog in the medicine world. So for me, I've always been someone that roots for the underdog, and I wanted to really do my part in making sure that in this area of medicine that is so crucial and vital, that just to do my part to give the respect and attention that it deserves.
I love my job. I love what I do. I'm a helper, regardless of the various roles I've served in different occupations. I've always been a helper. To
do my part to reduce the stigma of mental health. This idea that people are crazy, people are doing the best that they can with what they have in the moment.
Think about addiction, to really check some of the older or less helpful ideas that we might have about addiction, to really help to see the human element.
Conversations like this, but like with your friends, with your family, just letting it spread everywhere, because the less we talk about it, the worse it is.
Having conversations, sometimes the hard conversations, like teaching our patients to advocate for themselves, us being open and advocating for our needs, can really help fight the stigma and keep progressing towards mental health being a mainstream concern.
Representation matters. One of the reasons that I'm willing to do this, what we're doing right now, is because I do want to show people that they are represented in these spaces, especially at this level of care.
We're not embarrassed if your significant other has a heart attack. We're not embarrassed if somebody gets cancer, but somehow we have this stigma and shame around mental health.
Good question. And that's a hard question. But if I could go back and share with my niece and tell her just one more time that you are enough. Your mental illness does not define who you are. You know, there's a bright future out there for you. You may feel like you are burdened to the family, but not so.
It is a strength, not a weakness, to admit and to say, I'm suffering, I'm having difficulty with my anxiety or my depression, with my stress levels. They're interfering with my functioning, my concentration, my judgment. I need to get some help.
There is hope. You are not alone, and that it is okay not to be okay.
Just know that this is an illness. These are symptoms. This isn't who you are. Just reach out. We're here and we want to help.
Together as Buckeyes.
Together as Buckeyes.
Together as Buckeyes.
Together as Buckeyes.
Together as Buckeyes, we can
Help people reach out for help.
Talk openly.
Work together.
Be open.
Be honest.
Rise up.
Be intentional.
Educate ourselves.
And be compassionate.
We can be advocates and be the driving force.
Come together and connect to raise awareness for mental health.
What a remarkable display of dedication and commitment and compassion from those who participated in the video. I would like to say thank you to all who worked to put the video together, as well as to those who participated in the video itself. Now it's time to introduce our panel members. And I have the opportunity and the pleasure of introducing our panel members today. And I would like to start with Arianna Galligher, who is the Associate Director of the STAR Trauma Recovery Center, Partial Hospitalization and Intensive Outpatient Programming at OSU Harding Hospital. Arianna also develops and deploys programming to support faculty and staff at the OSU Wexner Medical Center and the health system in general, to assist them through their stresses that they experience in their day-to-day work through the Stress, Trauma, and Resilience, or STAR program. Next is Dr. Julie Hyman, who has been with OSU Harding for nearly 9 years. She is an inpatient psychiatrist on the second floor and has previous experience working in the outpatient clinic at Harding Hospital. Dr. Hyman is also the Associate Chief Quality Officer of Behavioral Health. Erica Mihely, MSW LISW-S, is a graduate of the Ohio State University College of Social Work Master's Program. She is manager of inpatient social work, which includes inpatient social workers, core social workers, and our PCRMs. Erica has been at OSU for going on 10 years, but has been working in the field for over 20 years as a social worker. Michelle Reynolds is a registered licensed occupational therapist and proud graduate of The Ohio State University. She has served as an occupational therapist at Harding Hospital for nearly 20 years, in addition to being a clinical instruction and coordinator for OT students. Lynn Snyder has been a certified therapeutic recreation specialist for 30 years. Yes, you've heard that correctly, for 30 years. With over 23 years at Ohio State, and has a great love for helping her patients improve their lives through recreational therapy. Dr. Walter Stearns is a board-certified psychiatrist who has been at OSU for over 5 years now. Dr. Stearns does a mix of inpatient and outpatient care, as well as research. He specializes in the treatment of psychotic disorders. Dr. Julie Teater is a psychiatrist and addiction medicine physician here in the Department of Psychiatry and Behavioral Health. She is the medical director of addiction medicine for the health system and serves as the Addiction Medicine Fellowship Program Director. And last but not least is Olivia Wells, who is a nurse on the young adult unit at Harding Hospital. Prior to nursing, Olivia earned her master's degrees in both international relations and anthropology. Her nursing practice is informed by her passion for cultural diversity and building relationships with our diverse patient population. Thank you and welcome all of you to today's panel. And thank you for taking time out of your busy schedules. So I would like to begin with a few questions that we had floated prior to today's event. And I was thinking I could start with Dr. Hyman. Dr. Hyman, a question was posed to us of how quickly do antidepressants work?
That's a great question, Ken. Thank you for that. So typically we say about 4 to 6 weeks would be the expected amount of time. That doesn't mean that there's no benefit at all until 4 to 6 weeks is reached. There may be some gradual benefit over that time frame. And for some individuals, it can even take a bit longer than that. So it is important to not give up too soon on the medication.
Thank you so much. That's great to know. If an individual has engaged in therapy in the past and it really hasn't helped them as much as they would have liked, is there a benefit for someone trying that again?
Absolutely. I sometimes make a comparison between medication and therapy in the sense that we wouldn't just try one medication and if it didn't work, say, well, medication's not going to work for a person. Likewise, if someone tries therapy once, I wouldn't use that as a reason to not try it again. We know that the fit of the therapist is very important, and it may take some trial and error to find the right therapist who's a good fit. And there are also many different modalities of therapy, from CBT to DBT to psychodynamic to other types of therapy as well. And also similarly to medication, dose can matter. So if someone tried therapy but only went once a month or once every 2 weeks, that may not have been a sufficient kind of quote unquote dose to know whether it could be helpful. Perhaps more intensive therapy would be beneficial.
Excellent. Thank you so much. Let's skip around a little bit. If I could ask Arianna Galligher, what is the value of group therapy in the partial hospital program and the intensive outpatient program?
That's a great question. I know a lot of people are sometimes a little apprehensive or hesitant to engage in a group-based therapy program, but the value of being in treatment with other people that have firsthand experience with the same or similar symptoms can really be valuable. One of the things that I think has been the most valuable for participants in our partial hospital and intensive outpatient programs is just seeing the growth of peers throughout the process over time. So sometimes it might be one individual's last day in the program and someone else's first day in the program. And being able to have that person who it's their last day offer some words of wisdom and offer a little bit of hope to the folks that are just coming into the program to say, 4 weeks ago, I was struggling in a way that is similar to how you're feeling today. And what I can tell you now is that it can get better and there is hope. And so that you can't put a price tag on. And just the feedback and the support that you get in a group setting, it also gives an opportunity to combat some of that stigma and internalized shame for experiencing these symptoms in the first place. It really helps people to know that they're not alone.
Excellent. Thanks for outlining the importance of those connections. That oftentimes the connections that patients have are actually equally to, if not more powerful than the staff connections. In a similar vein, I wonder, Michelle, we have a question that comes up for you is, are there myths or questions about occupational therapy that you've heard on a regular basis over your clinical years? And you are muted at the moment.
Okay. What was the question again? I'm so sorry.
Sure. So what are some of the myths or questions that you've had about occupational therapy over the years?
That's a good question. So one of the myths, Ken, that I often hear is occupational therapists, we just help people find jobs. And while that is true, we do focus on vocational rehabilitation. I honestly believe they think about work because they hear the word occupation. So while we want our patients to be successful in performing their job duties, we also have to look at what they need to do to get there. So before going to work, what are the tasks that they need to do before getting there? So for instance, okay, I want to go to work, but I also need to be able to get up to get dressed. So I need to get out of bed. I need to shower. I need to find the right clothing to put on to go to work. Maybe I want to make a small breakfast before going to work. And then the next piece of that is it's not just working, but how am I going to get there? I'm at a point in my life where I'm not able to drive, or should I continue to drive? How would I get to work? So can I access the community or navigate the community to get there using the bus system, calling an Uber, or maybe having a family member take me there? So again, it's more than just looking at work, but again, the pieces and parts that you need to get there to be able to do the job that you want to do. So other parts play a big piece of, being able to carry out a daily routine.
Wow, it sounds like you're kind of the glue that holds everything together. Thank you. What you do.
Thank you.
Similarly, if I could pick on Lynn Snyder for just a minute, what are some of the goals of recreational therapists? How might you address the goals with your patients?
Hey, Ken, thank you for asking that. So some of the things that we really, as recreation therapists, find useful is to focus on things like anxiety, stress, anger management, and symptom management through the use of coping skills. And we hope to provide the space and ideas to try different coping skills while they're here with us in this therapeutic setting. We work to help them with self-esteem. That's often an issue when people come in, they're kind of feeling at their lowest. So to build the self-worth and their self-esteem, their resilience is one of our goals, and trying to promote their own kind of personal empowerment. We offer emotional care, a lot of people have been isolated recently. So that's something that we're looking at, not only trying to decrease that, but also trying to teach them new ways to go out and be social and to build that support system. We try to connect our patients with some community recreation resources. So that might be an outlet for those purposes, so that their loneliness and the lack of social support kind of subsides if they do connect with that. Well, we do a lot of teaching of leisure education, kind of expanding upon what might have become a really small world for them in their recreation leisure interest, and trying to expand that. What else can you learn? What can you try to do? How can you incorporate that into your day? And sometimes it doesn't take a long time. Sometimes it takes 5 or 10 minutes to do a meditation or something that's calming and peaceful. We try to foster self-expression through creative means. We look at cognitive abilities, working on concentration and problem solving and planning, and physical abilities. We focus on strength and physical balance and range of motion, things like that. But overall, I guess you could say we really try to improve everybody's sense of well-being through what we do.
Wow. I think I need to schedule an appointment with you. I mean, all skills that we can all have and amplify. What a great answer. Thank you so much, Lynn.
Thank you, Ken.
Hi, Dr. Teater. How are you today? It's so nice to see you.
I'm good. It's great to see you too.
You know, you are in the area that is my passionate area as well, the area of addictions. And a question has come up that kind of poses the question is, how do you work? What is your work like with patients with substance use disorders? And I remember a gentleman who was at Talbot long before you arrived on the scene. His name, Dr. Marvin, and he mentioned to know addiction is to know health. And I think that was very true. Could you share your insights about what it is you do and how it is that you work with addiction and substance use disorder patients?
Sure, absolutely. So most of my clinical work is on the inpatient side. When people are really at their, often, worst, or, it's often said rock bottom, right? But actually someone else who preceded me once told me, so this is Dr. Pepper said, someone will never be more honest than they are in detox, which I've definitely found to be true. I think patients with substance use disorder often, have a lot of, they experience a lot of stigma, but there's also a lot of stigma from providers to them. And so I think there's this idea that they're manipulative and difficult to work with. And honestly, I've found, while that can be true in some settings, if you can align your goals with their goals, you can make a lot of progress together. The other really, what can be a very uplifting thing is that we have really good treatments, right? We have treatments that work, evidence-based treatments that we know can help people. So it's not necessarily, the case where something is uncurable, for example, right? Where we don't have a treatment for it. And so it's more a question of getting those treatments to people. And so that's why a lot of my work outside of Talbot has been focused on, okay, where do these patients come and where can we provide them evidence-based, high-quality treatment no matter where they present, not only if they walk into Harding or walk into Talbot, but if they're in the emergency room or on the consult services, because they're medically hospitalized due to infection, et cetera. So, I found actually the the population to be, really fulfilling to work with, and you can, over the long term, develop great relationships and see great progress.
You had mentioned Tom Pepper, Dr. Pepper. The one thing I remember him saying is substance use disorders are curable. We can make them go away, but we can place them into remission. And I think that's a point that's missed by many. That's really great that you're making. If you were to give one piece of advice about eliminating stigma around substance, what would that be?
Well, I don't know if it will be one, but on the one hand, we definitely have really good evidence of the brain changes that go on when someone's using substances. And in some ways, once you understand how the brain's really been hijacked by the substance, actually the behavior and what you see from there becomes completely logical, right? Many of our diseases are problems of insight, right? So that can be bipolar disorder and schizophrenia, but it's also true in substance use disorder. And it's often true that, one thing I think providers struggle with is it often seems that patients with substance use disorder are being illogical or acting against their own interest, right? They might say one thing like, I'm here because I want to get my kids back, right? Like that's my motivation to be sober. But then, they leave and relapse. But when you understand what's going on in their brain, that cycle becomes, again, very biologically driven and turns from something that seems very illogical on the surface to something that's very logical to their brain. So sort of working to interrupt that cycle, I think can really help reduce stigma when you understand where people are coming from.
Wonderful. It is a brain disorder. I really thank you for that information and insight. Mr. Stearns, if I may pick on you for just a moment, sir. It is interesting that we think about the overlapping nature of illness, and we have a question that has come in that is, what role does cannabis play in the development of psychotic disorders? And what are your thoughts on medical marijuana?
Thanks, Ken. So there's been a burgeoning literature base that cannabis, and especially delta-9 THC, which is the psychoactive component in cannabis, pretty clearly worsens psychotic disorders. So it's pretty strongly implicated in both hastening the appearance of a psychotic disorder, probably also being somewhat of a causative agent in people with some genetic susceptibility, and also causing like worsening symptoms and relapses in people with psychotic disorders. And this has been kind of a growing literature base in the past 10, 15 years. At the same time, what we've seen is a lot of states have begun to legalize marijuana, legalizing it for recreational purposes at times, but also giving it, you can get medical marijuana prescriptions. And one of the hard parts about the medical marijuana prescriptions is, depends what state you look at. If you look at Ohio, I think there's probably 20 indications for it. Most of the things, if you ever look at the evidence for it, there isn't a lot of evidence that marijuana actually helps these things. So none of these things would actually get FDA approval for this type of indication. So a lot of it's anecdotal evidence, but really what it is, it's saying that marijuana for many disorders has medicinal purpose, and it's almost like giving it a blessing, saying, well, it's a medicine now. So by doing that, it's saying it's safe. And really what we've seen with psychotic disorders is that it's not safe. It's actually quite harmful. And it's harmful in other regards for cognition for people who use it when they're younger, and worsening cognition and various things. So what we see is this kind of disconnect between kind of the evidence of the harmful effects of it, and then just the culturally sanctioned use of it, and kind of getting approval for its use. And makes it a very difficult conversation to have with patients who develop a psychotic disorder and you try to tell them to not use cannabis or marijuana, but they're hearing other things from other people and they're like, well, I'm prescribed it for this indication. Or like, well, you know, I can take it and it's safe. It's a medicine now. So what we're seeing is that this, you know, legalization is going to have like multifold effects. And my guess is in 5, 10, 15 years, you'll hear more about this. As is true probably because of the nature and stigma of these disorders. Like you don't hear much about it when you read about like the legalization of cannabis. You hear about other things, but you don't hear about this. But it's out there. The literature's out there. But I think a lot of it comes down to just kind of the idea of psychotic illnesses, schizophrenia in particular, that people almost think that it can't happen to them. You know, so it's almost like people are like, oh, that's not relevant for me. You know, and these are obviously illnesses that are quite common, very strongly genetic, you know, and this isn't a personal choice that someone has when they develop these things. But I think for those reasons, like the legalization of marijuana is problematic. And we'll see that even more so in the next 5, 10 years.
Yes, I think that's probably very, very true. At the same time, there are medications that are very effective for treating psychotic disorders. And I wonder if you could speak to what happens when someone is doing well on an antipsychotic, so well that in fact they decide they don't need to take it anymore. And what would your thoughts be on that? And how would you help to keep people away from stopping their medication? And are there any risks to abruptly stopping their medications?
Sure. So a lot of the antipsychotics have a host of side effects. You know, one of the reasons that they shouldn't be given, you know, just handed out willy-nilly is because of the side effect profile and what they can cause, like sedation, weight gain, movement issues. So the vast majority of them are generally not like pleasant to take. If someone's feeling better, you know, it seems that it makes sense to say, like, do I really need to keep taking this? So we'll see that a lot for people like who are doing better, responding well to the medicine, just because of the side effect profile. The caveat is that a couple-fold. So if someone has developed a psychotic disorder, schizophrenia, bipolar, the issue with stopping the medicine, it leaves them vulnerable to symptoms coming back. So one thing, symptoms can come back. And it's a very high likelihood that they will. Probably 85, 90% of the time, symptoms will come back at some point in time. So it's just a high probability in that regard. If they do come back, they can come back stronger than they did before, in the sense that it's not as simply as going back on the medicine and you'll go kind of back to where you were. The symptoms a lot of times can become a little bit more recalcitrant to treatment. So you would need to go on a stronger dose of the medicine, higher dose, go on a stronger medicine, and have kind of the more like the stronger side effect profiles. That being said, also, if symptoms come back, people don't always have insight right away. So by the nature of some psychotic symptoms, there isn't always a tremendous amount of insight. The nature of a delusion, for example, a delusion, a belief that a fixed false belief, a delusion comes back, someone doesn't come typically say I'm delusional again. You know, it would take a while for that to be recognized, probably by people around them. So in that time, a lot of things can happen by the nature of it, like bad things, dangerous things, like their life can get affected, suicide, violence, all these things can happen. So it's not just like, oh, you know, I'll notice it'll come back, I'll go back on the meds. So it's hard because there's probably a very small subset of people who probably can safely come off the medicine. We can't readily identify them though. So if you come off the medicine, it's a high risk kind of potentially high reward. But overall, if we think about, you know, 85, 90% of people will have symptoms return, I'll generally recommend that, you know, staying on the medicine indefinitely. But that's a hard pill to swallow for someone who's young. You know, a lot of these disorders develop late teenage years, early 20s. That's telling someone that they might need to be in treatment on medication indefinitely. That's a hard thing to kind of take. So we try to kind of, you know, slowly walk people through it, you know, and say like, always like say how, like time will tell and we'll try to work our best, but like, let's not have an immediate plan to come off the medicine.
Right. The complexity of the work you do is incredible. And I applaud your efforts. Thank you very much.
Thank you.
Olivia, how are you today?
I'm well. It's good to see everyone.
Thank you for being here. So we, from time to time, get questions that they go back to back. And I wanted to start with a very intriguing question for you. Is it frightening to work on a psychiatric unit? And a related question to that is, are psychiatric units, do they look like what we've seen in television and movies? Can you help us with that?
I would be honored to help. So to answer your first question, is it frightening? I don't find it frightening at all. I find it very fulfilling work. And I think as psych nurses, we're a bit of a self-selecting group. So people who work in psych mental health usually are there because they really want to be there and they're passionate about the patients that we care for. So no, like 99% of the time, there's nothing to be worried about. It's pretty calm and we watch Netflix sometimes with the patients. Like it's a very nice therapeutic environment. And I know that the nurses and our techs, we work really hard to keep it that way. So I think it's not frightening because we're doing a good job. The other answer to your question, is it like movies, TV? Not at all. It's really not. I mean, yeah, the nurses are handing out medication, but in a lot of movies and TV, you see kind of the nurses are behind an enclosed area and people come and line up and take their little cup of pills. Nothing like that. None of the violence that you might see. And I know that at Harding, like the way that our units are set up are more kind of pods, and we have a very nice open area in the middle. And in movies, you might see a long looming corridor and you don't know what's behind the doors. So we don't have any of that. It's just kind of a nice like communal environment. And on my floor where the young adults are staying, no, there's nothing to be scared of. A lot of people make nice friends and relationships because they're around people that understand what they're going through. So yeah, I think it's important to answer these questions. Thank you so much for asking.
Oh, thank you. So it's clear to me that you love your work, that it's your passion. What's your favorite part of the job that you do?
That's a great one. So I'm an anthropologist by training, and I've done intensive field work, different parts of the world. And part of being an anthropologist, I think, has made me a better psychiatric nurse, because in anthropology, it's a lot about building relationships with people and gaining trust, building that rapport, like we're told in nursing. So for me, my favorite part is just hearing different people's stories and getting to know them and what's important to them, and what they're like outside of the hospital. I think that's really important too, because we're seeing just a really short little cross section of who this person is. And I think it's very interesting to know what people are like, what excites them, what kind of work do they do, what are their goals. So hearing people's stories and kind of using that to inform their care, I think is a really rewarding part of my job.
So how do you take care of yourself, given the work that you do?
Yeah, I think this is really important for anybody in a caring profession, but especially mental health, right? Because we teach others about self-care and, making time for yourself and saying no sometimes. So I think to be a psychiatric nurse, I need to practice what I preach. So for me, I think it's a lot about alone time. I'm, believe it or not, really an introvert. So I'm very much recharged by alone time. So I need a lot of alone time. After work, I don't necessarily need to talk a lot. I'll talk when I'm ready. And, I think a nice hot bubble bath and just time with your family and friends and kind of debriefing with your coworkers, I think is really important, because in psychiatric nursing, our coworkers are really the only ones who understand what we're going through. And so if we have good relationships with them and can kind of hash things out and talk about things and share ideas, I think that's really good for our own mental health, is having these people we can chat with.
Wonderful. Thank you so much.
Thank you.
Shift gears and pick on Erica Mihely for a little bit here. Hi, Erica. How are you today?
I'm good, Dr. Yeager. Thanks.
It's so good to see you. Hey, could you give us a little bit of education about the work of the social workers in the unit? Like maybe what kind of linkages do they provide for the patients when the patients are ready to leave the hospital?
Yeah, so we're the background workers often. We're utilizing our trauma-informed care approaches to make sure we're providing the right next steps for all of our patients. As you know, when they come into us, they're in an emergency situation. They've just been through one of the hardest times of their lives, and they're trying to figure out, how do I get back to normal? So a big part of our planning is, how do we set that path for them to get there? So what we work really hard is those next steps and figure out what's appropriate, and maybe just relinkage with their counselor, and maybe making sure that they need something more intense. So we're linking them with Arianna's type of programming and things like that, with partial programming. But because we serve everyone from all different backgrounds, there's so many different things that we end up having to do. We serve people who are homeless, so we have to make sure they have all the right things in place to stay safe if we have to send them back to the community that way. We try to work with putting people in group homes, because we work with all different ages. With our young adult units, we're trying to get them connected back to the college, because a lot of them are students that have come from the university. So we're trying to get them the right services so that they can continue to grow academically and meet those expectations. If we have because I always tell everyone, we service everyone ages 18 to 100. So we're trying to go across all the different levels of care, from nursing homes to skilled nursing homes, to making sure they have the right physical therapy options and opportunities for them, the right resources. And then at the background of all that, we're doing the safety planning. We're making sure that they're contracting for safety, they're able to maintain, so that when they go home, their families still feel safe with them coming home. So we're also trying to talk with families to make sure there's a good plan in place, so that everyone feels good. Now that the emergency is kind of at a better place where everyone feels safe, we're going to transition them successfully. I always tell people, we're going to try this plan, but it's okay if you have to come back and you need a tune-up or another direction to go. But we're always just trying to get them to that next level to feel successful. So
it sounds to me like there is so much more involved than just linking with services. I kind of think like calling up my furnace repair guy, and that's a linking with service. But are social workers therapists too?
We are. I think there gets to be some confusion sometimes, is it just case management or those things. Our whole team does therapy on multiple levels. We do it from individual work, where we're providing CBT trainings. Our group facilitators, they're running 3 to 4 hours a group a day, focusing on dialectical behavior therapy and all of those different skill sets that help to promote that type of growth and help gain insight. So we're doing those things that benefit someone on an individual level, also in a group level, that make it a therapeutic approach. So we are therapists.
And it sounds like there's some family therapy in there as well when you're doing the discharge planning.
Oh yeah, we have them all. I know there was even a meeting this morning where a young person had such great success. We wanted to make sure the family knew how to keep it going. So we're always talking with families. We're doing that educational component for them, helping them understand the importance, and supporting the physicians with it. It's important that they stay on their meds. When you don't think that they are, please tell your outpatient providers, and are helping that kind of also guide them to keep the patient successful. So we're doing all of it, individual, family, group work. It's all kind of going on in the background to get the patient back to where they deserve to be.
Nice. What incredible work you're doing. It is again, as Dr. Stearns' work is it sounds very, very complex to me, everything that you're doing and where you are with everything. I have a general question that maybe anybody can jump in and answer. How has COVID impacted the mental health services you deliver, and have we seen an increase in mental illness as a result of COVID? Now, don't everyone talk at once; it'll goof up the process here. But somebody please talk.
I'll
go
talk.
first.
Oh,
Go, Julie, you go.
Go, Julie.
We can compliment each other.
A little bit about that. The things I've seen are increased isolation with people and sort of the initial process of kind of shutting down their lives to isolate for medical purposes and then continuing that. And then a struggle to sort of come out of that and get back to their usual life.
Okay. Yes. All right.
I'd like to add to that.
Okay, sure, Michelle.
I'm seeing that, there is a lack of routine with our patients. I'm hearing that every day since they have been isolated due to COVID. So therefore, some of them are having a hard time getting back to living. And so for me, my job is to teach the skills for the job of living. So I'm really focused on a daily routine. That's a huge part of my scope of practice. So again, having a daily routine may, reduce stress. It may improve time management because sometimes we get focused on doing a lot of things and we really aren't productive. So again, getting back to that routine has really been a struggle for many. And that's what I've really been focusing on because again, having a daily routine promotes health and wellness.
Absolutely. Dr. Teater, in the addictions area, what has the impact of COVID been and how has it impacted the population you're working with?
Yeah, it's been incredibly devastating, actually. So we've seen dramatic rise in overdose deaths over the last 2 years. As a state and country, we had previously peaked in 2017, but then 2020 and now 2021 are the most deadly years on record for overdose deaths. Probably about 70% of that, maybe a little more, is secondary to opiates, mainly fentanyl. And so, May 2020 was like the deadliest month on record. So, things like harm reduction services have become incredibly important. Many of you have been involved in Narcan distribution and other things, but in addition to that, fentanyl test strips, we have a contaminated drug supply. So it's actually incredibly common for someone to think they're using another substance, often like cocaine, but really it's fentanyl. But we have evidence that there is fentanyl in our amphetamine supply, our marijuana supply. And so testing of substances is incredibly important. But, as far as the causes of this, things that people mentioned, pretty immediately, things like mutual aid, AA, NA were shut down, right? People were disconnected. And it's often said that addiction is a disease of loneliness and disconnection, and reconnecting people can be a big part of the cure. And so there definitely was a spike of relapse and overdose.
Wow. Okay, thank you for that. Arianna, you had your hand up at one point. Can you talk about the impact?
Yeah, I would just say in general, folks that prior to the pandemic were experiencing more mild symptoms, the added stress and pressure typically amplified those mild symptoms to more of a moderate or severe category. Folks that were suffering and struggling prior to the pandemic They were struggling and suffering even more during the pandemic. And I'll just echo what everyone else has been saying about isolation, disruption to routine. Those are all really impactful factors when it comes to experiencing symptoms. And I would say professionals in certain career paths certainly bore the brunt more so than others. So we certainly saw an uptick in the level of stress for healthcare professionals and others in helping professions, and even those of us that work in mental health, feeling the weight and the pressure of the need and the demand for services versus in some areas lack of service during the pandemic. I think that was hugely impactful.
So I know the STAR program provides support for the staff of the medical center. How would a staff person access those services?
Great question. There are a few different ways. We do have a web page that folks can access, but probably the most direct route for connecting with STAR is to call the STAR line. So that's a pretty simple one. It's 293 STAR. So it's those last 4 digits are 7827. And any staff member that calls the STAR line, you just leave a quick message that says, hey, call me back. And we return the call within 24 hours to sort of connect with you about what the need relates to and what makes the most sense in terms of the kind of support that would be helpful. So that's probably the most direct route. There are lots of different options, including individual peer support, some group support. There are trainings that we can offer, lots of education, and sometimes it's just helpful to touch base and talk through a challenging situation. Another thing that we've been able to offer and hope to go back in person soon is short center rounds, which is a monthly socio-emotional kind of grand rounds conversation related to the stressors that are unique to working in healthcare. And so that sort of opportunity to gather and speak about some of these unique stressors can be really helpful for folks.
Thank you so much. I appreciate that plug for the STAR program. Dr. Hyman, can you speak to the increases, or are there increases in mental health issues secondary to the pandemic?
Yeah, absolutely. I mean, I think everyone else who spoke ahead of me really discussed what they've been seeing eloquently, and we're seeing that on the inpatient unit as well. I think one challenge has been delivering care in the context of COVID. During the Omicron surge, we saw a lot of folks showing up in mental health crisis and then incidentally finding out that they were COVID positive. And so needing to go to the medical side to complete isolation before they could access care at Harding. And in response to that, we did open a COVID positive psychiatric unit here at Harding, and it operated for approximately a month during the peak of that surge. And then thankfully we saw numbers decline enough that it was no longer needed. But that was another challenge in terms of folks getting the care they needed in the context of the pandemic.
Yes. And Erica, as people are going out from their hospitalizations and services, how has the pandemic affected the work of the social workers?
It's definitely been a challenge. We're seeing a surge in need and not enough social workers in the community. So anyone listening is considering going to social work school as a secondary option, go for it, and then call me when you're done. So I think that what we saw a lot of is a lot of the systems didn't know what to do in the community, so people just weren't seen. And then you have a large population of socioeconomically challenged persons out there that don't have resources, they don't have phones, they don't have access to things like they used to when the community was going to see them and going to find them. So there's been this stop of services, and now we're trying to get everyone relieved again. So we've kind of we're infiltrating the community, and it's starting to get backed up. So we're working really hard with our community partners to kind of decrease waits and things like that. But that's kind of been the outcome, is a lot of people just stopped and haven't seen anyone for over a year or more because they couldn't access it the way they were used to accessing it prior to the pandemic.
Right.
So that's been the major challenge for us, is to combat wait lists essentially for people to get care.
And access to care is still an enormous issue in Central Ohio.
Mm-hmm.
Yes. So thank you for all that you're doing with that. I am going to have to end the question and answer time. I would like to thank our panelists for their time and their expertise that has shed light on the treatment of those with mental health and addiction disorders. I would also like to thank our audience for taking the time out of your busy schedule to spend some time with us for today's event. And we, as OSU Harding, hope that you've learned a little more about the work that's being done at OSU Harding and Talbot Hall and the values that those bring to our community. Before I end, I would like to take a final minute to remind you all of the that's really hard to say. I'd like to remind you all of the mini mental health awareness walk that's being held next Tuesday, May the 10th. The walk will begin at 12 p.m. at OSU Harding Hospital. The walk is free to anyone that is interested in participating. The first 50 people who register and participate in the walk will receive a free t-shirt. So there you go, line up for your free t-shirts. Additional information can be found on the Mental Health Fair website, and the website link and a QR code for the site are on this screen, so you can see it. And if you're quick with the QR code, you connect right that way. And finally, as we're thinking about things moving forward, I would like to remind everyone that May is National Mental Health Month. It should be a year-long thing, but it is the month of May for the National Mental Health Month. And I would encourage you all to take some time this month, like was said in the video, to take time to consider how you might move the conversation forward, how you might share with others the importance of battling the stigma against mental illness. And I would really like to have your voices heard, as it helps to normalize mental illness as another disease that is very similar to heart disease, to diabetes, to cancer, and is very, very, very treatable. And I cannot thank you all enough for the work that you do on a daily basis. I don't think a month is enough to scream about the excellent work that you do, or the compassion that you share, or the kindness that you give in your day-to-day work. I thank you all for your time this afternoon, and I will turn it back over to Tammy if there's anything else that needs to be said here.
I think we're good. Thank you, everyone. Have a great day.
Thank you all. Have a wonderful day.